Hi there, my name is Ompa Musia. I'm a final year medical student at SMU, Sefako Mahato Health Sciences University. I'd like to go through the topic pelvic inflammatory disease. You are allowed to comment and tell me if you think I missed something or if you beg to differ with some of the points I may have put in here. This does not replace medical attention, medical consultations. If you suspect that you have any condition, you should still consult. I am just doing this for academic purposes and also for myself when I revise so that I can go through the video again. I can listen to myself again. The textbook that we use at SMU, it's Clinical Gynecology by Kruger and Botha. There's a new edition though. This is the 4th edition. I think there's a 5th edition that is in stores at the moment. So we're going through pelvic inflammatory disease, also known as PID. It's an acute infection of the upper genital tract structures in women. It involves any or all of the following, which is the uterus, the fallopian tubes, and the ovaries. It's often accompanied by involvement of the neighboring pelvic organs. Involvement of these structures will then result in endometritis, salpingitis, oophorytis, peritonitis, perihepatitis, and tubo-ovarian abscesses. The disease is usually sexually transmitted and may be acute or chronic in nature. So coming to the epidemiology of PID, in developed countries, the incidence is between 1 and 2%, and then in developing countries, it is quite higher at 6 to 20%. The incidence is higher also in adolescents than in other age groups. So we have risk factors which are associated with PID. This include early sexual encounter at an early age, women younger than 25 years, new or multiple or symptomatic partner, low parity, history of a previous PID attack or previous STIs, another concomitant STI that is existent at the time, low socioeconomic status, bacterial vaginosis, and having sexual intercourse during your menstrual period. Those are risk factors associated with PID. Coming to protective factors associated with PID, using barrier contraception, this is your IUDs, using oral contraception, tubal ligation, and pregnancy. Those are protective of PID. So the pathogenesis of PID, it is a community-acquired infection caused by a sexually transmitted agent, distinguishing it from pelvic infections caused by medical procedures, pregnancy, and other primary abdominal inflammatory conditions such as appendicitis. So the vaginal flora of most healthy women, normal women, includes a variety of potentially pathogenic bacteria. Among these bacteria are the streptococci, the staphylococci, enterobacteriaceae, Klebsiella, E. coli, and Proteus species, and a variety of anaerobes. So these organisms they are present in low numbers of concentration compared to the dominant hydrogen peroxide producing Lactobacillus acidophilus. So the complete disruption of the vaginal ecosystem can occur in which anaerobic bacteria assume predominance in a condition called bacterial vaginosis. The complete disruption of the vaginal ecosystem can occur in which anaerobic bacteria, assume predominance in that bacterial vaginosis. So up to 75% of cases of PID occur within 7 days of your menstrual period, during which time the cervical mucus favors the ascending spread of organisms to the upper genital tract. There is a transient documented increase in the risk of PID within the first 20 days after the placement of an intrauterine contraceptive device, possibly due to the introduction of bacteria in the upper genital tract. So there are organisms that are involved in PID. We have primary infecting agents and we have secondary invaders. On primary infecting agents, we have Neisseria gonorrhea and Chlamydia trachomatis, which is the most obligate intracellular parasite for PID. And then we also have Gardnerella vaginalis. And then on secondary invaders, these are organisms that are most normally found in the vagina, but then when they are sent to the upper urinary tract, they become involved in PID. So we have Streptococcus, as I mentioned earlier, E. coli, Haemophilus influenza, Proteus species, Staphylococcus species, Pseudomonas species, Klebsiella, Clostridium species, Peptococcus, Peptostreptococcus, and Ureaplasma urealyticum. We have less common infecting agents such as Mycobacterium tuberculosis. Yes, it can cause PID. Schistosoma hematobium and Actinomyces species. Mycoplasma pneumonia, Pneumococci Campylobacter species, Filaria, Enterobius vermicularis, Bacterioides, Parainfluenza, and Streptococcus agalactiae. So in the female genital tract, there are defense mechanisms. In the vulva, apposition of the labia majora is a defense mechanism. The rich blood supply promotes rapid healing, and we also have apocrine gland secretions, which have fungicidal properties. In the vagina, we have the absence of glands in the stratified squamous epithelium of the vagina, provides few entry sites for organisms. We have vaginal acidity, the lactic acid that is produced by gram-positive bacteria. And then we have vaginal flora, which are hydrogen peroxide producing lactobacilli. In the cervix, there's a mucus plug which has bacteriolytic properties. It obliterates the lumen of the cervix between the menstrual periods. And then in the uterus, the uterine epithelium is regularly shed, so that sheds away also with the bacteria. So coming to the pathology, in mild cases of PID, the fallopian tubes will be swollen and their serosal surfaces are hyperemic. The fallopian tubes are freely mobile and the tubal ostia are patent. A sticky seropurulent exudate is present at the fimbrial end. In moderate severe PID, fibrin deposits cover the serosal surfaces of the fallopian tubes, and then the fallopian tubes are not freely mobile and may adhere to the ovaries, broad ligament, or to the bowel. And then in severe PID, now the pelvic peritoneum is involved. And the tubal ostia are usually sealed, pelvic anatomy will be distorted, and there may be a tubal or a tubo-ovarian abscess, which can be replaced by serous fluid. Sometimes the pus of an abscess is replaced by the serous fluid, as I just mentioned, and the wall of the tube will become thinner and the mucosal folds will flatten. In extreme cases, restricted tubal mobility, extensive adhesions, and distorted anatomy may prevail, and that is usually called a frozen pelvis. So coming to the diagnosis of PID, PID represents a spectrum of infections. There is no single diagnostic gold standard for pelvic inflammatory disease, and the practical value of clinical diagnosis still remains important. As I said, if you have any symptoms or you suspect that you might have PID, you need to consult and not think that you just need to watch some YouTube video and think you are good to go. So usually lower abdominal pain is the cardinal presenting symptom in women with PID, although the character of the pain might be quite subtle. So there is a triad in the clinical diagnosis of PID. There's a triad of PID which contains of lower abdominal pain or tenderness in the lower abdomen. It may be dull or aching pain. And then there is cervical excitation or tenderness. And then there's adnexal and uterine tenderness. It can be unilateral or bilateral. That is the triad. And then there should also be one of the following present with the triad: a temperature of more than 38.3 degrees Celsius, abundant white blood cells on saline microscopy of the vaginal secretions, mucopurulent discharge from the cervix, an ESR, erythrocyte sedimentation rate of more than 15 millimeters per hour, and an elevated CRP, C-reactive protein. One of the following of those that I've just mentioned should be there together with the triad. I'll just go through the triad again. It's lower abdominal pain or tenderness, which may be dull or aching, cervical excitation tenderness, adnexal and uterine tenderness, which may be unilateral or bilateral. So the recent onset of pain that worsens during coitus or with cervical excitation tenderness during examination may be the only presenting symptom in some patients. The abdominal pain is usually bilateral and rarely of more than 2 weeks duration. Abnormal uterine bleeding occurs in 30% or more of the patients with PID. So now I'll be taking you through the cause of PID. A primary infective agent, I mentioned we have Neisseria gonorrhoeae, chlamydia trachomatis, one of those, or the Gardnerella vaginalis. Then it will it invades, the primary infective agent invades, and then it triggers an acute inflammatory response, which will result in cervicitis, endometritis, salpingitis. And then secondary invaders come into hand. These are the ones that are normally available in the genital tract as normal flora. So they will cause tissue destruction. So you have salpinges, which is pus formation within the fallopian tubes, and you may have a tubo-ovarian abscess. Then when it progresses, there will be rupture of the tubo-ovarian abscess, which may also cause a pelvic abscess. This is now severe disease. And then that can also result in generalized peritonitis, which results in morbidity and other sequelae of PID. So signs of PID. The signs depend on the severity of the disease. So a general examination may reveal an ill-looking patient who is dehydrated, pyrexic. In 50% of the patients, as I mentioned earlier, they will have a temperature of more than 38.3 degrees Celsius. They may present with tachycardia, hypotension, and tachypnea. An abdominal assessment may reveal a diffuse abdominal tenderness in lower quadrants, which may not be symmetrical, by the way. Rebound tenderness is common in most. A marked pain in the upper quadrant does not exclude pelvic inflammatory disease, because 10% of these patients may have perihepatitis. It's called Fitzhugh-Curtis syndrome. Generalized peritonitis may be due to a ruptured tubo-ovarian abscess. On pelvic examination, a mucopurulent endocervical discharge with cervical excitation tenderness is a common finding. Adnexal and uterine tenderness on bimanual examination may be present. In gonococcal-associated salpingitis, the lower abdominal pain is of sudden onset, usually less than 3 days, and more often correlates with menstrual bleeding. In non-gonococcal associated salpingitis, the onset is of of lower abdominal pain is later, maybe 5 to 7 days after invasion. So patients with chlamydial associated subpenitis are usually younger with minimal clinical findings but have longer duration of symptoms, which is 7 to 10 days. The patient with an anaerobic infection is usually older and presents with repetitive episodes of infection. The onset is usually acute, and the patient will be ill with pyrexia and demonstrates a palpable and adnexal mass. IUCD users have an increased rate of colonization with actinomyces in the upper genital tract. So there is a clinical staging system of pelvic inflammatory disease. This is the Gainesville classification. It was previously staged from stage 1 until stage 5, but has been updated to end in stage 4. I will take you up to stage 5, but I'll still mention the changes that have been made. In stage 1, it is early salpingitis. The tenderness is localized to the adnexa. And then in stage 2, there's late salpingitis, pelvic peritonitis. In stage 3, there's evidence of pyosalpinx, a tubo-ovarian mass, tubal occlusion, or an erythrocyte sedimentation rate of